So what's the problem? What problem was I looking at? Well, 3 or 4 years ago, senior management in my organisation wondered if quality improvement could be used more in public health practice. And at the same time, they had a bit of a hypothesis that quality improvement work had the potential to increase health inequalities if action wasn't taken about it. So at that point, I set about trying to investigate what could the core public health workforce, so those people in the workforce that are defined as engaged in public health activities as a primary part of their role, what could they do with QI to help contribute to a Scotland in which everyone could thrive? And then the flip side of that, what could the QI community do to achieve greater health equity through quality improvement work? So first of all, the quality the Q group in Scotland was a great source of knowledge and expertise for me as a relative newcomer to quality improvement. I quickly linked into David Elder, who I worked closely with. He is the Networks Advisor for Healthcare Improvement Scotland, and he helps to facilitate Q in Scotland on behalf of the Health Foundation. And through some semi-structured interviews, it became quite clear that the public health workforce didn't really think that quality improvement applied to their work, because they were more in the business of research and evidence-based research for public health. They were involved in influencing and relationships and influencing policy, but didn't really see it as applicable to their work. And on the flip side of that, the quality improvement community were saying, well, actually, we already do that. We already tackle equity because we cover it in our balancing measures, and that's how we do it. So no, thank you very much. We're fine with that. So there was a kind of acknowledgement at that point, or a sort of disagreement that there was a problem at all. So we went back and used the results from the research that we did with stakeholders to try and basically demonstrate that people in the quality improvement community felt that much more could be done to achieve greater equity and quality improvement. And at the same time, we looked at the evidence and reviewed the evidence from literature to show that QI without an equity lens there was evidence to show that it did increase health inequalities if you didn't take a lens on equity with that. So we were able to use that to help build will and conditions for change, going to lots of meetings, annoying people, basically pestering them and saying, have you thought about health inequalities? And they were like, who invited her? So that was sort of getting used to being unpopular, really. And we were able to use some of this evidence from literature and stakeholder perspectives to help build will and conditions for change. So as you can see, we didn't just do that with as you can see from this diagram, we used the improvement journey to guide our thinking, but not improvement science as such. We used our knowledge of networks, how networks behave. We used systems tools to help us map stakeholders and stakeholder initiatives and identify how patterns really that we could try and influence with that. And at this exact date last year, I was presenting at the Faculty of Public Health conference in Scotland to build will amongst them, to challenge them about what their role could be in influencing quality improvement for equity. So after engaging some people in that work, we then set about, don't expect you to, I'm not going to go through this, it's just to basically say this is something that we co-created. It's a picture of some work that we co-created with stakeholders from both quality improvement education initiatives and public health workforce. And we were able to use this to sort of generate discussion at online and face-to-face networking events between these disciplines, and use examples to demonstrate how some of the work was being applied in practice to help stimulate discussion and share experiences and learning about what could be done to reduce inequalities and where services could use QI thinking to do that. So through that work, we managed to engage around 400 members of the public health and quality improvement workforce. Some examples of the work that we shared. This was from a slide that colleague Graham Mackenzie, who was in the Q community in Scotland, previously public health consultant, now moved to GP land, but he liked this slide because it basically demonstrated how big thinking, so big picture thinking, which is often associated with public health mindset, could be combined with testing fast and smart, starting small from Plan, Do, Study, Act cycles. So he used Plan, Do, Study, Act with frontline practitioners and pregnant women to test how to increase uptake of healthy start vitamins during pregnancy, and used a lot of the learning and data that was generated from that work to influence national policy, which eventually led to measures to decrease poverty for maternal and around maternal and infant nutrition. Colin Sumpter, who you may have seen or may come across at this event, also presented around his work to bring his public health hat to bring an equity lens to service improvement work in Lothian, demonstrating the inequalities in service experience and the demands from those who were often from the most deprived areas in Lothian as well. Another example from our team at Public Health Scotland, one of our teams at Public Health Scotland is the local intelligence support team. So they have been doing work with local health and social care partnerships to help them stratify their population data to develop and improve services so that they're proportionate to needs. So I think that was referred to in Libby's presentation at the start. David Ansell talking about the need to provide in proportion to need for everyone to thrive. And also that I think also was mentioned was IHI's work. So we did link in with IHI at the start of this, the Institute of Healthcare Improvement in the States, who have a lot of intelligence about how to stratify population data for inequalities and inequities. So next steps. Well, we did have some plans until this thing came along. So we had plans this year to help make to do some more tests of change, really. And actually, in some ways, COVID has done a much better job of building will and conditions for change around health inequalities than we could have ever done with this. I think what COVID's done is it's brought health inequalities into people's direct personal experience in their lives, whereas before it was maybe conceptual for them and easy to ignore. So if anyone's familiar with Donald Schoen's work around ideas and good currency, health inequalities was not really an idea that was in good currency amongst the population. So COVID came along, created this threatening, disruptive event. And what we're starting to see now is solutions surfacing, networks galvanizing, but we feel like we can't take it for granted. So the work that we were planning on doing this year was to further institutionalize equity and quality improvement work. So increasing the focus of equity in some of the national quality improvement education programs, training data analysts in equity and how to stratify and challenge service improvers for population data, as well as more events to be able to share learning and experience amongst different sectors in public services in Scotland. So we still think that that can't be taken for granted. So future plans, well, public health is still a priority, as we know. So as well as COVID, our immediate public health priorities are poverty in children, linked to a fair and healthy economy, mental health and well-being, and communities in place. And so this sort of Venn diagram, which I realise is very oversimplified, that demonstrates the overlap of disciplines and where they may not have met, is that this is where the magic is going to happen. This is where the new thinking and knowledge and innovation is going to be generated. So we think that, you know, improving complex situations such as public health is going to take more of that, more building connections, more almost admitting that you don't know the answers to enable others and their experience and expertise to come to the fore. And on a more tangible level, we have plans to create a set of learning resources for a health inequalities learning hub, which is hosted on our virtual learning environment and due to launch at the end of this year. So we intend to promote that through Q Scotland as well as through the very small but still growing special interest group that we have as part of the Q community. So, so these resources are going to be available for everyone at no cost, and we hope that people will make use of them. We'd also encourage you to join the Achieving Equity Through QI subgroup that David Elder and I have been creating. And really we don't have the answers. We're admitting we don't have the answers to everything, but we can often signpost to people who have done similar work. So helping to broker connections to achieve equity through quality improvement or improvement work is our plan for that. And David Elder and I are both personally committed to this, and we hope to be able to resume some sort of normality at some point next year, where we can bring more of a focus to this work. So yeah, so thank you very much. That's all I'm going to say. If you have any questions, I'd be more than happy to answer or try and answer them if I can.